Hello, I think it's start time now. It's 1:15, and I can see Dr. Anant Patel, so I think we'll get started. So welcome everybody to our fifth COVID webinar. Just to please remind you all to put your cameras or videos on mute, and also please make use of the chat function on the right-hand side if you've got any questions. As always, this webinar is going to be recorded and available to colleagues should they need. And equally, please let us know if you've got topics that you would like to discuss on our next webinar, which will be Friday, the 3rd of July. So Anant did a great talk for us a couple of weeks ago on COVID and BAME, and today's is, I understand, about pollution. And air pollution. And following on from Anant, we've got Dr. Imogen Jones, who's going to be giving us a talk about COVID PCR and serology testing, which I think will be equally really interesting, especially as lots of colleagues have been getting their results of antibody tests back recently. So Anant, we'll go over to you.
Thanks very much, Francis.
Whilst he's doing that, Anant, can you tell us what that picture on the bottom left is?
The picture on the bottom left is a tumor growing out from someone's left upper lobe, because there's good quality evidence now that air pollution causes lung cancer. And in particular, I think there's some emerging data to demonstrate that it causes lung adenocarcinoma, particularly in women, particularly in their 30s, 40s, and 50s, who have never smoked. And it's something that I'm seeing more and more of in my role as lead for lung cancer here. Okay, please do unmute and stop me as we go along. Can I have the next slide, please? So I just want to briefly go over what's the problem, what are the COVID-specific issues, and what must we do, not what should we do. I'm going to be a bit more forthright about this, and hopefully you'll see why as we go along. Next slide, please. And here it is, spoiler alert. What's the problem? It's incredibly poisonous. Not all air pollution is the same, and some of it's much worse than others, and it's quite a heterogeneous term. What I'm going to talk about most today is tailpipe emissions from transport, but obviously from some industrial sources as well. What are the COVID-specific issues? Well, there's a bit of misinformation around there, and a huge issue over many decades of a reluctance to change from a systemic point of view. And what must we do? Stop burning stuff. Easy as that. Next slide, please. So we've known for many decades, I think I made this point last time, that smoking kills people. We've known for decades, actually, that air pollution also actively harms human health. Not quite to the same effect size for every individual, but on a population level, the numbers are really scary. Next slide, please. And we must prevent what we cannot cure. It is an old adage, I think, that we have to bear in mind when it comes to air pollution. Next slide, please. Of the things that cause people to die across the planet, these are the top 5. And in Britain, it's slightly different in that dementia is up there as number 3, the number 1 cause in women now. Lung cancer is number 2 in men across England and Wales. But by and large, the top few are as they are, almost all of which are driven by multifactorial problems. But we know that for each of these, air pollution plays a huge role, not only in the development of the disease in the first place, but in the events that accompany them. So, for example, MIs in the form of ischemic heart disease, stroke events rather than just carotid atherosclerosis, exacerbations of COPD, and formation of lung cancer, as I mentioned at the beginning. Next slide, please. And we've seen pictures like this. On the left is the kind of picture that we've got used to over conurbations across the planet over many decades now. And the picture on the right is a more recent picture during lockdown, when there are far fewer roadside and industrial emissions. Industrial emissions probably didn't change a huge amount during lockdown, but roadside emissions absolutely did. And the difference it's made is enormous, both visually as well as scientifically in terms of proper measurements. We'll come on to that. Next slide, please. My colleague, Dr. James Brand, one of my respiratory medicine colleagues here, cycles into work every day. And this is his route down the A1 and into the distance, in the middle of the lockdown, or kind of towards the end of the lockdown, you can see the skyline really clearly into the distance. You can see the Shard in the distance all the way across into South London. And in the middle, you've got an image as lockdown was beginning to ease, and then as things have completely opened up. These are really early morning pictures as these come in. And on the 12th of June, you can see that skyline has completely disappeared into this veritable smog. Next slide, please. So what exactly are we talking about here? And what role do they play in terms of human health? So, like I said, I'm going to focus on tailpipe emissions mostly. And what we're talking about here is sulfur dioxide from burning of petrol and particularly diesel, nitrogen dioxide, particularly from diesel, ozone, carbon monoxide, particulate matter is a term that's bandied around a lot. And there are various measurements that we can make. PM10 are particles that are smaller than 10 micrometers across. PM2.5 likewise, and PM0.1 much more difficult to measure, much less often measured. But the smaller a particle is, the further it can get in a suspension that we breathe in air into our alveoli, into our circulation very, very easily without too much difficulty at all. And there's good evidence that air pollution particles penetrate every single cell in our body. Next slide, please. And so on the finest beach you've ever been to, the sand grains are about 90 microns across for comparison. A human hair, 50 microns for fine hair. And so what we're talking about are really kind of much smaller particles than these things that we can see. PM10 you can mostly see, and James Brown's pictures are likely to be PM10s that we're seeing as a big suspension in the air. But PM2.5 you cannot see, you cannot smell. It doesn't cause disruption of light particularly. And the legal limit for PM2.5 is the thing that a lot of people talk about. But actually, there's emerging evidence that it's that nanoparticle range, less than 0.1 microns. Those particles are the ones that really cause huge damage to human health because of their ability to penetrate into our circulation, into our tissues, because of their ability to help disrupt atherosclerotic plaque. And those effects, actually, we're seeing more and more in modern times because combustion engines have got more efficient and the particles that come out are smaller. So you'll see that out of a catalytic converter, most of the bigger particles are kept back, but actually a lot of the finer ones are let go, and that's what people breathe in. So our legal limit in the UK is more than 2.5 times the legal limit recommended from the WHO, which is 10 micrograms per meter. Now, they call this a safe legal limit, but actually there is no level of air pollution that is safe. So the effect sizes go down even beyond below this level. So really the lower the better. Next slide, please. And this is where we are in London. And so this is 13 out of the 14 teaching hospitals across London are above the legal limit according to the WHO limits. Mary's and UCLH are amongst the most polluted areas in Europe. So actually they're sitting in the middle of a big toxic soup on main arterial roads. But even up here on the verge of Hampstead Heath, here we are above the legal limit. Next slide, please. And this is a map of London. So the pollution that we're measuring here is from roadside monitors, and this is nitrogen dioxide. And you can make out the anatomy of London. You can see the city of London. You can make out the North Circular, part of the South Circular. You can see Heathrow to the west, and the further out you go across the region, you can see it gets bluer with lower limits, lower values, sorry. And the limit is where we see anything that's not green and blue, which is within limits, but everything that's yellow, orange, and red is well above the limits, and you can make out exactly where they are on the roads. Next slide, please. And so I've said it can get into every organ in the body, but actually a lot of these particles don't travel very far. They travel relatively short distances out of a tailpipe, and the humans that are at greatest risk of breathing these particles in are those that are 2 and 3 feet high. So not me at almost 6 foot, but actually my 2.5-year-old son, who is about 2 and a bit foot. And I'll just leave that image there for you. These are emissions that are coming out at child height, at pram height. A child at their height is breathing in 30% more than we would breathe in between 5 and 6 feet up in the air. A lot of roadside monitors, air pollution monitors, are hung up on lampposts, on higher places, on buildings, but when we bring them down to the roadside, the effect is incredibly scary. Emissions are far higher than we've been measuring for many years. And if you measure what happens at the very edge of the curbside compared to what happens next to a building on a pavement, there can be a difference as much as 100%, so a doubling of the particle dose that people breathe in at the curbside itself. So the closer you are to a tailpipe, the higher the emissions. Children that grow up close to an arterial road have, on average, about between 12 and 14% less lung function. So we're poisoning kids from an early age who live on the roadside, and which kids live and play and go to school near roadsides. It's those from our most deprived communities. It's those often people that are affected in the same way that we talked about in the last talk that we did. Next slide, please. But what happened during lockdown was that we've mentioned that particle pollution, nitrogen dioxide pollution, came tumbling down, and at the end of lockdown, it's gone back up at least to the same level, and actually some evidence showing it's gone higher now after after June, after the easing of lockdown, because many more people are driving their individual transport vehicles along, less people taking public transport, and actually higher emissions than even beforehand. Next slide, please. And that's data from across the country, not just in the major conurbations, but absolutely everywhere. Next slide, please. And so this is a number of countries across Europe, and in the red at the bottom you can see a 37% reduction in nitrogen dioxide across the month of, or the 30 days before the 24th of April. On average, a 12% decrease in PM10 particle pollution, which makes a visible difference across cities. Next slide, please. And this helped. We think, by estimates, that somewhere between 800 and 3,000 people avoided dying during the month of April because of less air pollution. That's a huge number of people. Of course, more than that died from COVID in the meantime, and a lockdown has huge implications across society. But imagine what a future would be like if we had clean air to breathe in, this many people alive, just in a month. I'm not going to patronize you with comparisons of numbers of Grenfell Towers or numbers of Lockerbies or whatever, other dreadful tragedies that befell our nation, but this is a huge number of people. Next slide, please. And it's from a number of particularly cerebrovascular, coronary artery vascular, and airway diseases in particular, which I showed you at the beginning, are the leading causes of death. Here we can see during March and well into the end of May, the number of asthma attendants is well down. And of course, partly driven by people not wanting to come in, but actually these are conditions when they get bad, people just turn up anyway, regardless of how scared they are of coming. So you can see that the latest data shows, particularly in terms of myocardial ischemia, that these are coming back, particularly as the lockdown eased. Next slide, please. And actually, a lot of the Public Health England document that came out last time was quite roundly criticised by some environmental scientists for not including air pollution as one of the factors, particularly because we know it disproportionately affects communities who are in the black and minority ethnic groups. And this is a study from Harvard, pre-print and pre-peer review, so take it with a pinch of salt, but a clear association with mortality from COVID, according to the quintile of air pollution across 3,000 counties of the United States. An incredibly powerful predictor when you adjust it for everything else. If you live in the 4th and 5th highest polluted areas of the US compared to the least polluted 40%, you're about 2 times more likely to die of COVID than you were if you breathed cleaner air. Next slide, please. And some of the microscopic descriptions of how COVID affects people's lungs and how it affects people's arteries make sense why air pollution at this kind of very small nanoparticle and microparticle level can penetrate into people's lungs. So where the black arrows are in the top right panel are microthrombi. And we know that these particles act as a nidus of platelets and fibrin to form around them, causing microthrombi. Next slide, please. So there's a biological, plausible explanation of why people that breathe in more air pollution may be more severely affected by COVID. I'm not going to talk too much about this. You've seen lots of headlines about how long we've got left to save the planet. The answer is we just need to do something, and we need to do something quickly, both on a personal, institutional, and national level. Next slide, please. This was a 9-year-old girl who died, age 9. She lived yards from the South Circular Road in London, one of the busiest places in London, not far from where I live in southeast London. And I get shivers down my spine when I see this picture of her looking like a really wonderful young girl who died as a result, almost certainly, of air pollution near her home. The spikes in air pollution matched exactly when she had worsening of her asthma and attended hospital 27 times in the 3 years before her death with dreadful asthma. And hers is only a prominent case, probably because her mother, Rosamond, has done an incredible job in campaigning for more understanding about air pollution, how it affects human health, particularly for those people that live close to arterial roads. I drove back in the day before 2013 when she died. Before then, I drove my petrol engine car down this road regularly and have contributed in no small way to her death, which is an incredibly uncomfortable feeling to have. And she's not the only one. She's very far from being the only one. And very shortly, probably after the inquest is finished, the air pollution will be listed on the cause of death for many more people. Next slide, please. So what should we do? What must we do to breathe cleaner air, to allow our patients, our friends, our relatives, our colleagues to breathe cleaner air? I would put to you, it's really easy and better to move to zero-emission transport. Electric cars, electric vans, electric buses are a reality now. They're available. They're more expensive to buy at the moment. That price is coming down as battery technology improves. Where we lag behind a bit is charging infrastructure. But again, that's not insurmountable, and things change very quickly. And if people doubt the ability of motorists, of organizations who run fleets to change quickly, we only have to look a decade and a half ago when we thought that diesel vehicles were the way forward because the carbon footprint was less. We didn't take into account the NO2, the sulfur dioxide, and some of the other particulate matter that was spewing out at huge rates, even with the cheating that went on in measuring them. And so we moved from an exclusively petrol driving society to at least 50% diesel across Europe in 5 years. And we can make that change to electric transport in a similar rate of time, I would put to you. Heating is a bit more difficult, but there are really effective and cheaper ways of doing that, if we want to talk about that later. And I'm not talking about just each of us as individuals. I'm talking about us in our smaller organizations, in your practices, in my hospital, in your professional societies, the Royal College of GPs, in my case, Royal College of Physicians, British Thoracic Society. We all have a part to play in lobbying these people to help us make the world a better place. In no small way, we are scientifically literate, we are influential, and we are articulate, be able to explain this to other people as a huge issue. In 50 years' time, we would look back on this era with shame. I'm absolutely sure of that. Disinvesting in oil companies, fossil fuel companies, is something that's being done slowly but surely, but the more weight that we add behind that in terms of where the really big money is, pension scheme, investment funds, is important. And actually, over the next few years, it's probably likely, as we move towards a zero-carbon society, that we're going to have to measure our carbon footprint with various aspects of what we do, not least in healthcare. I'll give you a very small example that I have for the last 4 years not prescribed almost any pressurized metered dose inhalers, PMDIs, because of their greenhouse gas element. The HFAs in that are more than 2,500 times more powerful as greenhouse than carbon dioxide. And it's a measurable, reasonably, about somewhere between 4 and 8% of the entire NHS carbon footprint comes from these inhalers. So I've stopped using them, and I would encourage you to do the same. I have a chance to talk about that if we have time. And using our political influence in the same way. Next slide, please. So I'll just leave you with a message that we must prevent what we cannot cure. Thank you.
Thank you very much, Dr. Patel. That's quite sobering data there. People can chat away if they've got any questions for Anant. I can't see anything on the chat. Sometimes my chat doesn't work though.
I can't see anything either.
Okay, you can't see anything either.
I think I've really made everyone incredibly miserable.
I think Anant, I'm in a room with 4 other doctors, and
let me try and cheer you up with one offer to you.
Okay.
I offer to you that you can drive my car for as long as you want, with no charge, nothing. Come and see what electric vehicles are like. They're just better. They honestly are in every way. They cost almost nothing to run. There's a bit of hassle in charging them from time to time because I don't have a driveway. If you've got a driveway, it's an absolute no-brainer. If you're a practice and you've got a car parking space, you can get the council to install a charger really easily. It's very straightforward. It's the way forward, I promise you.
Thank you. I think what I found most depressing was the data about the children, and actually how when you're walking your child to school, just how much more exposed they are than an adult. And I certainly didn't. I didn't really think of that statistical difference before now. That was very, very powerful presentation. Thank you.
Hello. Mind if I just ask you a quick question?
Please do.
Thank you for that presentation. Really powerful, as everyone's saying. I just wonder, we have been informed that there are lots of people not turning up to A&E. We're missing lots of MIs and cases in acute sector as well as in general practice. But your presentation, I think, highlights the fact that there is essentially a reason for that. People are perhaps at home more compliant with medication, taking more exercise and less polluted environments. Is that what your feeling is? That there is a case for that as well?
There are two really big factors to this. The first being less air pollution, and I think there's good solid data to suggest that. Also, the reduction in number of non-COVID viral infections that have been circulating in the community with less social interaction. So I think those two things have made a big difference in less events and less illness that usually require admission to hospital, usually require a visit to the GP.
Thanks. There's a question here that someone would be more interested to hear about the women with adenocarcinomas that you mentioned, that picture. Can you just expand on that a little bit?
Yes. So the old risk factors for lung cancer were generally smoking, a very small element of background natural radiation, usually from igneous rocks, granite in particular. So the risk of developing lung cancer is a bit higher in Cornwall, in the middle of the Iberian Peninsula, than it is in southeast England. And so there are some background natural things that we can't really help that play a small role. But generally speaking, smoking. And because smoking was so prevalent in society, particularly amongst men, those were the groups that we saw many more of. But we are now out-diagnosing men with lung cancer with women, and at a younger age than ever before. And when you take a history from these people of where they grew up, what their kind of very local area was like, you can often see a big stark indication of why they were at risk as a never smoker often. So it used to be something like, when I started officer training, about 7% of our lung cancers were in people that have never smoked. It's now approaching 15%, and that number's going up all the time, of people that have never smoked. And the reason why we're seeing more peripheral lung adenocarcinomas, sometimes which start off slowly and more insidious to begin with, but then can grow, metastasize when they grow into a solid element, when there's lymphovascular invasion, is that the particles that get into their lungs are getting deeper into their lungs than they ever did before. The pollution that people were exposed to in the 50s and 60s and smog of 52, etc., were generally large particles, generally from burning coal. Now what we're breathing in is burning from what we think of as more efficient engines, but actually they're creating particles that go deeper into people's lungs. And in particular, even in smokers, we've got particles that are going far deeper into people's lungs. The way that cigarette filters have changed essentially allow finer particles to get all the way through, but make sure that people have to breathe harder to get the same hit of nicotine when you've got a tighter filter. By the way, filters are relatively ineffective at kind of preventing any kind of disease. And the colouring that you see, a brown-orange kind of colouring in a cigarette filter, after it's been used, is not the tar that it's collecting. It tends not to do that. What you're seeing is an artificial colorant when exposed to one of the chemicals inside. So actually, this is all very artificial. But people are smoking cigarettes further and harder and breathing them deeper in, coupled with the number of women that started smoking in the 60s in particular and have carried on to this day in the UK. That's why we're seeing an explosion of women who either used to smoke in the past or have never smoked now, because the particles are just getting further into their lungs. The type of DNA damage it tends to cause tends to be a bit different.
Thanks. Can you see the questions about mask wearing on there? Does wearing a mask help, and filter masks?
Yeah. So filter masks, if cycling, help keep out large particles. And the closer you are to the back end of a bus or other diesel transport vehicles, the more a mask is likely to make a difference. But it doesn't stop the small stuff getting in, unless you invest in masks that cost hundreds of pounds and have very tight filters. And they are available and they're coming down in price, and they will become more prevalent as time goes on. So they help to some extent, but actually, even if you don't have a mask and you cycle into work, the exercise benefit, the health benefit of exercise, almost certainly outweighs the health risk from breathing in pollution. And so walking is more of an issue when you're not really getting the cardiorespiratory effort you get when you're cycling. Now with e-bikes coming in, I think it's great that we're going to have people that are doing less it's great that people are going to be using hopefully cars less and fossil fuels less. But actually my concern is that the health impact of breathing in polluted air across longer distances through the middle of town is going to play a role as well. So I think it's really important that we advocate the use of effective masks, but cheap ones are not effective, essentially. I'm sorry to hear about from Sarah, who had a best friend who was a GP who died of lung adenocarcinoma at age 35 with a 2-year-old. Unfortunately, this year I've seen about 6 similar cases already, 1 a month. It's awful.
When I looked, Anant, I saw that there was an association with pregnancy and postpartum. Is there anything in that with adeno-CA?
Yes. So the way that adenocarcinoma, so essentially we think that DNA mutation is incredibly common, and it doesn't affect the kind of minority that develop clinically significant lung cancers or other cancers later on. But the immune system does a good job in kind of shutting down abnormal cells, recognizing them and getting rid of them. The hormonal interplay between the way that the immune system deals with DNA mutated cells is probably quite profound, and we are just at the very vanguard, the beginning of understanding that process of the epigenetics of hormonal changes, the epigenetics of how exercise might change that. We don't really understand it really well yet. I understand that there is an association like you described. We don't understand quite why and how it happens or what we can do to prevent it. What I would put to you is that what we ought to do is breathe cleaner air and not have those DNA mutations in the first place. The greener inhaler agenda is a national one we've been discussing locally at CIH Respiratory Group. We've agreed reducing the carbon footprint is wider than switching inhalers, as well as ensuring right device selected for the patient. DPI versions of inhalers can be more costly, especially salbutamol has a wider budget consideration across the health economy. Is your approach reflective for all at RFH? In fairness, I've only just put it to my colleagues. I've sent them some evidence, some detailed evidence about this, including the whole life cycle of inhalers. And in my view, there is no real argument to be had that so let me give you an example. 2 puffs of pressurized meter-dose inhaler is the equivalent of 550 liters of carbon dioxide. It's an enormous environmental cost. If we are going to not have islands go underwater, have entire ecosystems destroyed, we have to make this change. So I don't particularly give a monkey's, if I'm entirely honest, if the budget for respiratory prescribing goes up by 15 grand, whatever it is, for modest health changes. I'm not sure how much is going to change. Maybe someone can inform me how much more expensive this. The answer is I don't think it's particularly that much more expensive. And if there is a big clamoring from us nationally, the companies will change and they'll provide us with the products that we want and we can negotiate them down. If you've got a patient who uses their salbutamol 10 times a day, that's what's happening. 5,500 liters of carbon dioxide. Can I recommend a branded mask? I'm sorry, I can't. I did look into this ages ago when I looked into an electric scooter. I can't recall. I'm sorry. You're going to have to Google a brand of mask to filter out.
Thank you, Anna.
I'm keen to hear any comeback about the inhaler story, and any kind of feelings that you guys have about that. Be as mean and aggressive as you like.
I think we've got a small group of doctors here, and the general consensus is, actually we're all quite shocked, but also, we work with the NHS with about a huge recession, and how practical is this task is really. But
the easy thing is when you start someone on a new inhaler, start them on a DPI, really straightforward, and you can often find exactly the right one. Terbutalin's not that expensive compared to salbutamol.
I think what's helpful is we've got Caroline from our medicines management team on the call. So, Caroline, we can charge you with maybe taking this away to your wider medicines management team, and maybe this is something we can support being a bit more proactive on moving forward.
Thank you. That was Sarah Morgan there. Thank you, Sarah, for that. Are we anywhere near close to having Imogen on the call? Yeah. Imogen, I think you're...
Imogen is in the house. I'm very excited.
Excellent. So Imogen's going to talk to us about testing for COVID in all forms. So Imogen, we'll hand over to you now.
Great, thank you. All right, fine. So yeah, I'm going to talk about the 3 types of swab, the 3 types of tests that we're generally doing, which is PCR, serology, and very sort of briefly about culture in terms of what it means in terms of infectivity when we find PCR positive on a swab. Can I have the next slide, please? So PCR is generally a nose or throat or combined swab, although it can be done on other body fluids, for example, in lower respiratory tract infections like sputum or BAL fluid and things like that when patients are hospitalised, which may increase the sensitivity of it somewhat. And diagnosis an acute infection, so it's detectable viral RNA in this area sampled. And so it's very specific because you have, in the next slide, it shows that you've got these sort of specific primers and probes that are targeted at the organism that you're looking for. So in this case, the SARS-CoV-2 virus. And so you don't get very many false negative results, but it does depend on the amount of virus sampled and things like that. So the test itself, just to give a bit of background, you take your sample, you extract the nucleic material that you're interested in, either RNA or DNA, and then it goes through these heating and cooling cycles, and you eventually get over. If you're positive, then during these cycles, it will reach a limit of detection and sort of go over the threshold. And so when you're looking at samples, also when you're looking at studies talking about PCR, you'll often see the CT value, and the CT value is the cycle time threshold. So how many cycles of heating and cooling it took for the product to get over the threshold of detection. So if you can go on to the next slide, I think there's a small diagram there which just shows you've got these specific primers and probes which can exponentially increase as it's heated and cooled. As it's heated, the nucleic acid breaks apart into separate strands, and then you make new strands with your primers, and this is how it exponentially increases. And on the next slide, you can see that. And you can just see these are the graphs that come off of the results. And so this one with a large amount of virus in the sample has a low cycle threshold because it's only taken 15 cycles to get over the threshold, whereas this one, where there's a smaller amount of virus, it's sort of up to 31. And so the test generally goes up to 40. Of interest potentially, they haven't been able to culture virus in any tests where they've done PCR and virus culture simultaneously. They haven't been able to culture any when the cycle threshold has been greater than 24, so sort of indicating that there's quite low levels of virus in those patients, and therefore probably the infectivity isn't so high. If you go on to the next slide, we just talk about the sensitivity. So certainly it's not a perfect test. Partly it may depend on the primers and the probes used, because we know that there can be mutations and things like that. So you want to try and aim for a relatively well-conserved region, but you also want it to be specific enough for the organism that you're looking for, that you won't get cross-reactivity, such as with seasonal coronaviruses. And part of the problem is that we don't have a gold standard to compare it to. So a lot of the studies that have looked at sensitivity of the test, the sort of criteria for inclusion as being a positive case is that you end up having a positive swab eventually. But we know there are some patients who definitely have COVID disease who never have a positive upper airway swab. Potentially some of those patients we might diagnose it on CT criteria, or we might diagnose it from a lower respiratory tract sample instead. But the studies that are looking at sensitivity are probably going to be biased by that somewhat. It partly depends on how good a sample is taken. So you can see here, a good nasopharyngeal swab is probably quite uncomfortable, needs to go right to the back of the nasopharynx. And some of the tests are now incorporating positive controls for finding human cells as well as the coronavirus to make sure that a good enough swab has been taken. Definitely, some of the systematic reviews suggest that it does depend on the day of illness and the degree of your symptoms. So there's a systematic review, this one in the Annals of Internal Medicine, where there was a study which followed people who had exposure to coronavirus and swabbed them daily after their exposure. And on day one of exposure, 100% of them were negative, going up to, I think, 80% positive day 3 after symptom onset. But so still 20% of those patients on that highest yield day were negative. We know that potentially we don't know how many people we're missing who have symptomatic infection or asymptomatic infection, because from some of the sero studies we'll see that people don't necessarily have positive swabs but do seroconvert anyway. So it's certainly not a perfect test, but most of the range of sensitivity puts it between sort of about 70 to 98% sensitive, and that may be partly on repeated swabbing. So one single negative swab is probably about 70 to 80% sensitive from the information that we have at the moment. Can we go on to the next slide? And so what does this mean in practice? Because it's very specific, we're not likely to get false positives. And so a positive test is highly likely to mean that you have COVID, sort of pretty much definitely. But a single negative test doesn't rule it out, particularly if the pretest probability is high. And this can be quite hard in the current climate, because we know that the local rates of COVID are changing. And, we're always going to be a bit behind the curve. We're anxiously waiting for the second wave at the moment, but it doesn't seem to have arrived yet. Pre-test probability is affected by signs and symptoms as well, but we see that our current case definition here certainly doesn't catch everybody that has a COVID infection. Obviously this will also be affected by likelihood of alternative diagnosis and history of exposure. And this table just comes from a BMG practice paper, which was referenced on the previous slide, and I think is referenced on the next slide as well. So if people are interested to look at it as a kind of practice pointer about how to interpret a COVID test, particularly talking about PCR, and shows that if your pretest probability, so sort of, in that last week of March, if you had a patient who had fever, cough, anosmia, and a housemate that had confirmed COVID-19, if your pretest probability is really high, even with one negative test, based on a sensitivity of 70%, specificity of 95%, you're still 74%. There's still a 74% chance that you have COVID, and even with two negative tests, there's still a 47% chance that you have COVID. So, it does depend on the pretest probability, but it is sort of important to think about when interpreting this test, and it's definitely, they aren't perfect for some of the reasons that we've discussed. One of the questions that I haven't been able to answer when looking into this is, we certainly know that people seem to be most infectious, in their pre-symptomatic period and in the first few days of illness, but it's odd that that seems to be the time that we find it hardest to detect the virus from the upper respiratory tract. So I don't have an answer for that, I'm afraid, at the moment. Can you go on to the next slide, please? So just in terms of working out pretest probability, this is from the PHE weekly surveillance report, mentioning the RCGP swabbing scheme, and just looking at the rates. This is from the week 25 report. So obviously rates in London have come right down, but there is still circulating virus around, we know, and we know that as the lockdown ends, this is probably going to change. Can we have the next slide, please? And this is, as I say, this is from this BMJ paper again, and they've got a kind of interactive calculator that you can have a look at just in terms of playing around with the sort of changing the pretest probability with a given test sensitivity and specificity, and working out what your positive and negative test means, and may be helpful in trying to interpret the test that we're getting back. Okay, next slide. So does PCR positivity equate to infectivity? Certainly not necessarily, but it does depend on the day of symptoms. So we know that people can shed virus up to sort of 2 months at least after onset of symptoms. And most of the studies that have looked at it so far have only been able to detect culturable virus, which we would see as a proxy for infective virus, up to 8 to 9 days after onset of symptoms. There's been a few studies now that have all sort of put this in about the same range in terms of being able to identify culturable virus. We don't know about the infectivity of asymptomatic people. I did read one thing that said, maybe they are not as infected because they're not producing as many respiratory droplets if they're not coughing and sneezing, etc. But we know that we do produce respiratory droplets when we talk, when we sing, etc. So it depends what they're doing while they're in that asymptomatic period. Next slide, please. So, antibody testing is more of a test to see if you've had the disease, not necessarily useful during acute infection. And again, well, it's potentially more useful on a population-based level than individually, and because we don't really know what a positive antibody means. There isn't huge amounts of evidence at the moment that it confers protection against reinfection, or that a negative antibody in somebody who's had a previously PCR confirmed case means that they're more susceptible to getting infection. Next slide, please. In terms of the seroprevalence, this is from, again, that PHE surveillance report, looking at blood donors, and there was a ONS seroprevalence study, I think, that sort of correlates with this a few weeks ago, showing that in London, the seroprevalence was about 17%, and in the rest of the UK, about 5%. But so, it can be useful in terms of estimating the amount of the population who've had it. But again, it isn't a perfect test. So if we go on to the next slide, we can have a look. So PHE have recently validated 3 tests for use, the Roche, Abbott, and Ortho Diagnostics, and just the sensitivity here ranging from between 77 to 92%. And just to point out that they are validated only for venous blood draws and not finger prick tests. And so I think one of the issues over the last few weeks is that some commercial suppliers started offering these on finger prick tests, but then had to withdraw them because it was pointed out that they hadn't been validated yet. Next slide, please. And UCLH are using the Roche test, so this is just a little bit more detail from the PHE validation document, which shows that the sensitivity does seem to increase the further out you get from symptoms. So these people had symptoms, or these people were admitted to hospital. They didn't have a symptom onset date, but they had a hospital admission date less than 10 days, and the sensitivity rose the longer you'd had symptoms, but still up to a maximum there of 93.3%. So still missing some. And then on the next slide, just showing these are the negative tests. So the negatives were samples from pre-2019 from various stored serum. They had the confounders are things like rheumatoid factor positive, people with CMV antibodies, etc. So looking for things that can often give false positive results, which they didn't seem to find with this test. But it is certainly not 100% sensitive and is missing some. And on the next slide, you can see there is a correlation with increasing amounts of antibody the further you get from symptom onset. But even still, there are some people who are not having antibody detected even 40 days later. And I think Sarah made the point in an email previously that these are all hospitalised patients that are being studied. So we don't know, these are people who are probably on the spectrum of disease, had a much more severe disease than a lot of the patients that we'll be seeing in general practice who may now have the antibody test available to them. So we don't know how this test is going to perform once it's being used in the general population. So this is something that will need to be under review. We can go to the next slide. So again, what does this mean for our patients? It's quite difficult to interpret, and we don't know how the results are going to compare. One of the populations which is being studied fairly heavily at the moment, however, is healthcare workers, and can help to shed some light on sort of asymptomatic infection, on antibodies, etc. So on the next slide, I just talk about a couple of studies that have been published in the last few weeks. They're both preprint. So this one was from Birmingham, where they did a cross-sectional study of 554 asymptomatic patients on one day. So so by definition, you had to be asymptomatic because you had to be at work and not self-isolating at home. On that day, 2.3% of them had detectable RNA on the swab, although I'm not sure from the study how many of those people had, that could have been the tail end of an infection, we're not sure. And then just looking down here, it showed that those, they had a 24.4% rate of seroconversion on that day. I think that 26% of them had a prior symptomatic COVID illness that they reported. So sort of 70-odd% were asymptomatic, and those people who were asymptomatic had a quantitatively lower level of antibody measured. That's what this graph is showing, than the people who had prior symptoms. There does seem to be some discrepancy with people who are asymptomatic, or maybe a lower level of antibody measure with those who are asymptomatic. On the next slide, I think we talk about the SAFER study, which is a UCLH-based study, which is a longitudinal one following healthcare workers in London and Liverpool. And this is the report from the first month in London, where they enrolled 200 healthcare workers, and they're doing twice weekly nose and throat swabs, which are self-taken and monthly antibody tests. In this first month, 21% were positive in at least one nose and throat swab, and of those that were positive, only 20% met the current case definition. And I think on the next slide, I've just got a table which shows that 20% of them have cough or fever or anosmia. 64% were asymptomatic. A higher proportion did have symptoms, but they, the highest number of symptoms was runny nose, sore throat, headache. So we will be missing some people with the current case definition as well. And then in terms of serology in that study, at baseline, 25% of them were positive. So this was recruited between, I think, the 26th of March and the 8th of April, so slightly earlier than that Birmingham one. So there was 25% of people positive at baseline, another 20% seroconverted during the study. So we were left with 45% of the study population being seropositive at the end of that. On the next slide, I think that's all I've got to say at the moment. So, I mean, there is new evidence coming to light all the time. It's quite difficult to keep up. Everybody's still learning, and I'm very happy to answer questions.
That's great, Imogen. Thank you so much. So I think if people want to chip in with questions on video, or they can go into chat function, please go ahead and ask. I don't know if anyone. Yeah, I think it's really interesting that the studies that validated have such numbers. That's something that I'm really amazed at, actually.
Well, the ones that were validated at PA2?
Yes.
Okay. I mean, certainly, I mean, the manufacturers had done much higher numbers. They were sort of, I think, 4,000 or 5,000 samples. But obviously, you know, and I guess some of that will be, you know, they will continue to look at. I guess I don't know whether they'll do further validation actually once they sort of have further samples or once it's in use in multiple labs across the country. I'm not quite sure what happens because I think a lot of labs then will locally validate it. But yeah, no, you're right. It's quite small numbers in terms of the validation.
If you've got any questions, anybody, please do ask, either for Dr. Patel or Dr. Jones, or for Dr. Sarah Logan, who's also on call today. I don't know, actually, Anant and Sarah and Imogen, can you guys give us a bit of an idea about the pre-probability rate of COVID in London now? As in, you know, are you seeing patients with COVID admitted? And I think a lot of the GPs here, and certainly at the hub, we're getting referrals for young children with a fever, for example. And my take has generally been it's really not likely to be COVID given the situation, but perhaps you could keep us, just give us some insight. I've not been in the sort of acute admitting areas this week, and it does change so rapidly. So sort of a couple of weeks before when I was, the main, we were mainly seeing it, I think, in healthcare workers actually. So, you know, there seem to be some pockets of transmission still, but I don't know whether, Sarah, you have been on take, I think, a bit more recently.
Yeah, I mean, I think it's probably the same at the Free, that there does seem cases coming in the front door as a result of Black Lives Matter marches, and now would be about the time to see those people. And we haven't seen that. And I think that's quite interesting, because I think that we have, as a nation, placed a lot of emphasis on understanding how many people have had infections on the basis of their serology. And I think as we're all appreciating, serology is not going to be a very good marker of immunity to this virus. And I know, Francis, you've had colleagues who've been swab positive and who are serologically negative, and we're certainly getting that at UCLH. So the steady trickle through the door are, as Imogen says, generally healthcare workers. We had a little mini outbreak, if you like, amongst ITU nurses a couple of weeks ago, where when we did some fairly rigorous contact testing of the whole of the ITU as a result of 2 positive cases who were admitted, we had 15 out of 200 nurses who were swab positive. I think I would say that the thing that I'm really appreciating about the serology, really from the SAFER study, so you've got 25%, a quarter of the people who joined SAFER. Admittedly, you joined SAFER probably because you thought it was your only way to get an antibody test, but you joined SAFER on the 26th of March, and 25% of those people had a syndrome. If you retested those people now, they might still have some antibodies, but a lot less. So I do think there's a lot of people who had an illness in London in early March, late February, who we will not identify, and we won't really know how protected they are until we get a second wave of COVID.
Experience of the Free is very similar.
There's a question here about when will Y testing for patients be available, and that's certainly something that I am being asked by patients all the time. Is there any direction, Sarah or Anna, do you know anything about this?
I think it depends. It depends what you're asking, Sarah Morgan, in the sense that wide testing for doing self-swabbing is available if you meet a case definition. If you're meaning in terms of the antibodies, and it comes back to really why we're doing that antibody test, because as I think I've tried to explain, I really don't think we understand enough about how good that is to convey any confidence as to whether people are protected, have had it. So I don't think there is a big push to nationally make that available. I think that there is a very good rationale for testing specific community level COVID patients. For example, I think there really should be availability for a GP who's seeing a patient who reports a good history of anosmia to do their antibody test if that person really wants that. And of course that is available at the moment, just not on the NHS. And you can send them off to Abbott, to HSL or Abbott and Roche directly via TDL, and you can get those tests done. It's just that they're not on the NHS at the moment.
The Islington GPs were just saying that they had been told that they could request tests and were sort of, at their discretion, they were doing it quite widely. So I don't know whether there's, they've got a different contract, or I'm not quite sure how it works, but they certainly were saying that it'd be made available.
Yeah, I think the answer to that is, and I just messaged Phil Taylor, who did a talk 2 weeks ago about antibody testing for staff. And certainly I think that in NCL, we don't have the go-ahead yet to test it on patients. So I think it is a regional thing. But my understanding is that NCL, we don't have the go-ahead just yet.
In terms of the Royal Free, we're seeing, as Sarah described, a small trickle as well. I think we've had less than 10 new cases in the last week. I think I personally have diagnosed more TB than I have COVID this week.
Yeah, I think we're also seeing, as I'm sure you all are in primary care, the effects of delayed presentation. And I'm sure Anant will be seeing that particularly with respiratory presentations, but there's definitely evidence of the unanticipated consequences of lockdown are definitely a bigger problem.
Absolutely, completely agree.
Thanks. I think we'll just have the last shout for questions. And perhaps also, if anybody has some burning topics they'd like for our next webinar, if you could let us know, and we can certainly look into that. I don't know if Dr. Patel, Sarah Logan, or Imogen Jones, Dr. Jones, if anyone has anything else to say?
Well, Jonathan's just asked, and I was just about to reply in the chat, but I agree with Jonathan Levy that I think patients want to know, and I've certainly done some venipuncture on friends at the school gates who've accessed their tests. People want to know if they've had COVID, but I agree with you, Jonathan. I'm not really sure what a negative test means. I think a positive test is quite helpful for people, not necessarily because I want them to go around not wearing a mask on the tube and not wearing and not socially distancing, but for some people who, for example, might want to go and see shielded family and things, I think there is a degree of confidence that an antibody test gives you.
Can I just ask a quick follow-up to that, Sarah, which is, have we seen anywhere on the planet any good evidence of reinfection? I know there were some Korean cases which were probably kind of positive all along.
Yeah, exactly, Anand. So I think, and Jonathan's questions along that line, is it valid to be confident in that? And I think it is, actually. And I mean, we haven't seen it yet, and of course we're really only going to be able to answer that question in about a year or so's time. But I think we've got to assume that when you've got a virus that isn't changing a lot in terms of what it looks like, and that it's relatively conserved genetic sequence, that if you have had it once, you will be immune to it for at least the next 6 months, I would imagine. So I think it is a valid serological confidence.
Thank you.
Thanks. I think I read a virology headline a few weeks ago where it did say for other coronaviruses you would be thinking at something like 16 to 21 months, where you're pretty certain kind of worst case and best case maybe 3 years or more. And that's other coronaviruses, not necessarily this. But I agree, I think it does give you some confidence for a bit of time.
Yeah.
Okay, I think we're winding down now. Thank you to Anant and to Sarah and to Imogen as well. Thank you, Imogen, although we couldn't see you. And we hope to see everybody again in 2 weeks' time. Thank you.
Thanks, guys.
Bye.